and he wanted a presentation on antibiotic stewardship from an infection preventionist point of view. And so I reached out to Terry Hewlett. Terry is a great friend of mine and a colleague, and we have worked together. Some of you may remember the infection prevention webinars that we presented a couple years ago, and Terry was my partner in that. Terry holds a bachelor's degree in nursing. She's board certified in infection prevention and control, and she has earned the designation of fellow in the Association for Professionals in Infection Control and Epidemiology. She's been in nursing for 41 years, which is hard to believe because she was probably 8 years old when she started. Her experience includes 27 years as a bedside nurse, and her specialty was neonatal ICU. She transitioned from the bedside to infection prevention in 2006, and over her 10 years in IP, she's been involved in multiple projects, both at the local, regional, and national level. And she has done some work with antibiotic stewardship, I believe, in the regional and national level. As an infection preventionist, Terry has served in multiple leadership roles in the local level, including president of APIC Mile High, Colorado. She is the legislative or chapter legislative representative for the APIC Montana chapter, and she has also served as the national at the national level with APIC as chair of the APIC Education Committee, and that committee has produced some really outstanding educational programs. So it is my great pleasure to introduce you to Terry Hewlett, who is going to do a fantastic job for you today. So Terry, I'll hand it over to you.
Okay. Thank you. I am honored to have the opportunity to share some of my experience and how I've been involved with antibiotic stewardship. Pam, I don't see the slide deck.
Oh, Jenner, do you have the slide deck?
I've got to share my screen. There should be a
I've got mine
green button at the bottom that will say share screen.
Do you have that at the bottom of your screen?
I don't.
Oh, that's interesting. Let me. Do you have it now?
Breakout rooms. No.
Yeah, Terry, it's right at the bottom. Like if you go to the bottom, at the very left is mute, stop video, participants, chat, and then share screen.
I don't. I have mute, a start video from.
I will share my screen.
Yeah, go ahead.
There you go.
Just tell me next slide.
Okay, next slide. Yeah. So implementing antibiotic stewardship, big topic, hard to implement, especially in the small and critical access facilities. And so hopefully we'll be able to share some good information with you guys today. Next slide. Nothing to disclose. Next slide. Objectives. We'll touch base briefly on the antibiotic stewardship core elements at small and critical access hospitals. I won't go into any great detail because my suspicion is that you guys have seen them, you guys have discussed them, and if you have questions, we can address at that point. Next, we'll go over some literature on implementing antibiotic stewardship in the small and critical access hospitals, and then again, I'll share some of my experiences with antibiotic stewardship over the last 10 years or so. Next slide. So this is the core elements for critical access hospitals. The introduction in the core elements document states that improving antibiotic use in hospitals is imperative to improving patient outcomes. And what we know is that antibiotics used inappropriately can have unintended consequences, including C. diff and other adverse events. Next slide. So this is just a list of the core elements, the 7 core elements identified, and the core elements are the same regardless of the setting that you're in. I'm going to focus on the last 4 core elements: action, tracking, reporting, and education, primarily because leadership, accountability, and drug expertise just didn't fall into what I want to talk about today. All the 7 core elements are important, but again, we'll focus on those last 4. Next slide. So targeted core elements so these are the last 4 in the core elements of the antibiotic stewardship. And for each of the individual ones, I've put in what the core elements give as suggestions that you can do. So for action, thinking about antibiotic timeouts, making sure that you review your labs, looking at your bug-drug mismatch. For tracking your antibiotic timeout again, conversion from IV to PO. So these are the traditional interventions that are in the core elements. And we'll talk about this later in the presentation. Next slide. So one of the things that I like to do is coming at things from that, if you give teaching somebody to fish versus just feeding them the fish. So I like to share the different tools that are out there and the value that I see in the tools, especially those that are available at no cost and that really can help drive the work. So the National Quality Partners Playbook, if you guys haven't seen it, it's a really good tool. It's on the, you can Google it free of charge. It's a tool that was put together using a practical approach to antibiotic stewardship. The National Quality Forum released it in 2017, and it provides strategies that build on the CDC's core elements for antibiotic stewardship. Dr. Srinivasan and Dr. Septimus were kind of the leads in this work. Dr. Srinivasan is at the CDC, and his take on the playbook was that it will provide a flexible structure with real-world examples for hospitals to use as they create high-quality antibiotic stewardship programs. And the quality playbook addresses across the board. So not just large facilities, but small critical access facilities. And it gives you good information for everything. Next slide. For me, the quality playbook is almost better than the core elements, because in the playbook, and I realize that it's probably small print for you guys, so hard to read, but it doesn't just tell you what you need to do, but it gives you real world examples. And it has links to all of the different things. So it breaks down each of the core elements into a basic approach, which is where you think about a system-wide intervention, an intermediate approach where you think about a patient-specific intervention. So when I think of examples, and the work that I've done for system-wide intervention, we did a blood culture contamination project that eventually went system-wide because it had impact system-wide. For the patient-specific intervention, I think about those IV to PO timeouts, stuff like that. And then if you already have your basic in place and you've got good intermediate interventions in place and you really want to develop a more robust program, then you can look at those advanced options that the playbook lays out. And when they talk about advanced options, they're looking at diagnosis and infection-specific interventions. I think the other thing that I like about the playbook is that it not only gives you options for your interventions to implement, but it also addresses proactively potential barriers and suggested solutions. And those are barriers and solutions that the people who developed this playbook, who all came together and shared their work, they were real world barriers, and then how they addressed them. And again, they have links to all of the tools that these different facilities and different groups used. Next slide. So the PEW Charitable Trust is another group that I have had the honor to work with. They came out, and again, a lot of this work came out like in 2016, 2017, when there really started to be a huge focus on the need for true antibiotic stewardship. So the PEW Charitable Trust put together a path to better antibiotic stewardship in inpatient settings. And what they did is they pulled together 10 different facilities from across the country. The facilities were selected as a way to describe a wide variety of institutions. So there's long-term care facilities, there's critical access hospitals, there's rural facilities or community facilities, and then large academic medical centers. And they wanted to give that diverse look from financial, staff resources, what's been able to be implemented and where they had challenges. And so in their opening document, they talk about how antibiotics should be used only to treat bacterial infections and should be prescribed only in doses and for durations appropriate for the patient and infection being treated. And yet the CDC states that up to 50% of all antibiotics prescribed in the US continue to be unnecessary or inappropriate, with many of them prescribed in inpatient settings. So the majority of the facilities in this document are inpatient acute care settings. Next slide. So there's a lot of information in that document, but what I wanted to kind of pull out of it was a few of the lessons learned, and it will drive the rest of my presentation. So frontline nurses were viewed as being essential to monitoring and improving antibiotic use. The ability to link antibiotic use with an increase in C. diff, one of the facilities was able to do that, and it was kind of impressive. Training a variety of staff members on antibiotic stewardship programs can help ingrain stewardship into a facility's culture. And for me, that's a key piece right there. We can speak till we're blue in the face. We can be out on units. We can teach until the cows come home. But if we're not working to change the culture in a facility or on a unit, it's almost as if that work is useless. And so for me, that was one of the key lessons learned. And then another lesson that they pointed out was well-respected champions are critical, implementing a multidisciplinary stewardship approach. And several of the studies and documents that I've read talk about having a well-respected champion. And that champion doesn't necessarily have to be the ID physician or the ID pharmacist, but it needs to be somebody who carries a level of respect that people will listen to and go the extra mile for. And then the last bullet here, nurses assess patients, communicate symptoms, and then monitor response to intervention. So again, kind of a non-traditional member of an antibiotic stewardship program, which will be kind of the rest of my discussion. We'll focus on nursing. Next slide. So one of the things that we discovered in 2016 and 2017 when we were meeting with the PEW Charitable Trust and working on some of those National Quality Forum documents is that nursing really is at the heart of everything. And so realizing that nurses are allies to the antibiotic stewardship team helped kind of broaden that approach to antibiotic stewardship teams. And so when we talk about a multidisciplinary approach, we don't just think of the traditional group of people that are listed in the initial core elements document that came out. And what this article talks about is how a multidisciplinary approach can help bolster support for your antibiotic stewardship program, engage providers, and ensure adherence to stewardship policies. And if we think about the nurses, they're at the bedside, they're with those patients all the time. They're kind of the go-between from patients to providers, and providers to the lab and pharmacy. They're that one person that has connections with everybody. In small hospitals, having multidisciplinary representation is ideal, but not always feasible. And I learned that as I started working with those small critical access hospitals. And coming from a large academic medical center, we had money and we had funding and we had people that served in all these different roles. So as an IP, that was my only hat. As a pharmacist, that was in a large academic medical center, that was their only hat. And we were fortunate enough to even have an antibiotic stewardship specific pharmacist. So it was educational and a real learning for me to get out and work with the small critical access hospitals when the hospital manager in one place was also the pharmacist, because they didn't have a full-time pharmacist and they worked with their community pharmacists sometimes depending on what they needed. So again, just thinking outside of the box. And I think that's kind of what this article gets to. Realizing that it's essential to engage your frontline staff and ensure that nursing is part of your team. Infection prevention has always kind of been included, but not necessarily the driver. And I think what we've realized in those facilities that are not large academic medical centers is that your nursing and your IP can be drivers in a lot of this work. Next slide. So this is just another article that supports the role of having nursing as part of your antibiotic stewardship program. For me, the title was kind of key. The critical role of the staff nurse in antimicrobial stewardship, unrecognized, but already there. And so this picture on the left, the table on the left, they listed out the different roles from nursing to microbiology to case management, pharmacy, and then they plotted all the different things for antibiotic stewardship program work that is done. And if you look under nursing, pretty much everything that goes on with antibiotic stewardship, nursing has a part of in some way, shape, or form. So again, just this is a good article that shows why we should not miss the opportunity to include nursing as a critical role. Next slide. So this was one, again, in that 2016, 2017 time period when we were realizing that we needed to really figure out how we were going to move antibiotic stewardship forward at the unit level. And the American Nurses Association and CEC and some other groups came together and realized that we needed to start thinking about nursing. So they put out this white paper. It's on the CDC website. And the picture on the right is actually in the document. And for me, it was a good picture of how nursing really does play. Nursing sits between the patient and the family, and then everybody else in the hospital. And I mentioned that earlier. Nurses interact with pharmacy. Nurses interact with case management. Nurses interact with infection prevention and control and with micro. So they really become that central communicator, that hub of a lot of the work that's going on. Next slide. This is in the ANA article. And again, it just highlights the role that nursing is already doing, the work that nursing is already doing specific to some of the antimicrobial stewardship functions. And so it just stresses that nurses initially assess the source of infection. Nurses are the first ones to see the patients. If cultures need to be obtained, those nurses are going to do it. Nurses review, oftentimes will get called from the lab with culture results. The bug-drug mismatch, we've worked more and more with nursing to help them understand what that means and what it is, understanding their role in antibiotic timeouts, and then how they can be a part of antibiotic de-escalation. Next slide. So this is the same slide from the beginning, but what I did was for the action tracking, reporting, and education, I put in the nursing functions that would work for each of those. And so if you think about the core elements, it doesn't say who has to do what, and it doesn't say that you have to do a ton of things. You have to do one thing for each of the core elements. And you can pick what that one thing is going to be. So nursing collects the cultures. We can impact antibiotic stewardship by making sure that that culture is obtained correctly. Nursing can, during rounds with providers, institute the discussion about antibiotic timeouts. IV to PO, nurses know when those patients have gone from IV fluids to oral antibiotics. And not only can they drive getting that patient from IV to PO antibiotics, but once we can get them on PO, we can get the devices out of them and reduce risk for infections that way. Tracking, reporting, we forget that nurses do a lot of reporting. They report lab results, they report adverse events. So just thinking about how nursing fits into the bigger picture of antibiotic stewardship. I think a key piece for me with the education is in all of the core elements, the education work is focused around educating providers, educating clinicians, educating pharmacists. But when we think about nursing, nurses do a lot of education. They educate families on antibiotics. They can, as we build those key respected leaders, they then can go on to educate their coworkers in nursing handoff at the end of the shift, making sure that they're talking about what antibiotic the patient is on, why the patient is on it, when the antibiotic should be done. So just options to think about in terms of your antibiotic stewardship program and how you're going to make it really functional. Next slide. Diagnostic stewardship is a big piece, and it plays into antibiotic stewardship because if we're not obtaining inappropriate or unnecessary diagnostic tests, and the big one that comes to mind is getting urine cultures on anybody that comes into the ED, whether they have an indication for that or not, or obtaining urine cultures on a patient that is admitted to the hospital from the nursing home and they have an indwelling urinary catheter that is cloudy and has some sediment in it. No indication, patients being admitted maybe for a fall and there's concern they have a broken hip, but nursing automatically pulls a urine culture and it's a dirty urine, and the next thing we know, they're misdiagnosed with a UTI and they're being treated with antibiotics. So diagnostic stewardship is another big piece, and we can educate. The nurses need to be the ones that are educated on some key pieces around diagnostic stewardship. Next slide. This is a study that was done again in 2017. It was published in JAMA, and it's a really short 2-page article that really goes into some good detail about diagnostic stewardship, what it is and why we should be paying attention to it. And kind of the key things for me in reading about it was diagnostic stewardship involves modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. And it just follows along with the nursing piece of things. If we don't start out with a good test that has a good indication, and if we're not making sure that that culture is being obtained appropriately, we run the risk of misdiagnosis and then being treated for maybe an asymptomatic bacteriuria or a contaminated blood culture. Next slide. I don't know if you guys have heard, if anybody's used device stewardship, but when I was still at the large academic medical center, one of the big things that we really tried to focus on was devices. How long have those devices been in? Do they still need them? Paying attention to the lines that we have in our patients. And my background being neonatal ICU, I was one of the ones who would, in that 1 kilo baby, say, can we keep that line one more day? I don't want to pull that line yet. And until I went into infection prevention, I didn't realize the harm, the potential harm by leaving lines in unnecessarily. Helping nursing understand that If that peripheral IV is not needed, let's get it out. Even a peripheral IV can have detrimental effects to a patient if it develops an infection at the site. And then again, the catheter, teaching them that, teaching nursing that there are options for getting the indwelling urinary catheter out, and the benefit of straight cath versus an indwelling urinary catheter if that indwelling urinary catheter is not called for. Next slide. I shared this tool and I came across it accidentally, the culture of culturing, and it was put together by Dr. Faki, who is phenomenal and has done a ton of work around antibiotic stewardship and the culture of culturing. And so this shows really the value that needs to be put into getting good cultures, knowing when to get cultures. It addresses why send urine cultures. It addresses indication for urine cultures. It identifies urine culture triggers. So if you at your facility wanted to put something in place, this is a good document to look at in terms of the triggers, how to reduce unnecessary urine cultures, and then what to do with positive urine cultures. Next slide. So what this is out of that culture of culturing, and part of why I like this is because this table summarizes situations where urine cultures should or should not be obtained, and it addresses it from the patient who has an indwelling urinary catheter. Easy to understand, short and simple, and this for me was easy to use as a training and education document when I would go out to the units, because you can explain what pyorrhea is and why it's important or why it's not important, and then give staff opportunities to ask questions. Next slide. I think this is one of my last articles to share with you guys, but it was another good one, and for me, this was a key article. Nurse-driven antibiotic engagement tool. And so this was an article put together by a group of nurses who really took to heart that nurses needed to be intimately involved with antibiotic stewardship. And what the study identified was that clarifying antibiotic duration was a prime area for future nursing antibiotic stewardship efforts. Nurses identified antibiotic stop discrepancies, and then nurses found this tool, and I'll go into detail about the tool, but they found the ADIOS tool helpful to build confidence, and it fostered discussion with and between the clinical team. So for me, thinking about the teams in a small critical access hospital, they often don't have access to an ID trained pharmacist, or they don't have access to an ID physician on a regular basis, on a daily basis. And so this just helps build some of those pieces that they might miss otherwise. And then the units that implemented the use of the ADIOS tool had a higher level of leadership involvement. And I thought that was an interesting piece. Next slide. So this is the ADIOS antibiotic engagement tool. And what ADIOS stands for is antimicrobials, duration, indication, oral. And for the oral, it's talking about, is it an opportunity to switch them from IV to oral antibiotics? Are they on oral intake, and can we make that switch? And then it leaves an opportunity for suggestions for the nursing staff to ask questions. And this can be used in handoff from shift to shift. It can be used to have a discussion with the provider during rounds. So the tool on the left is the engagement tool, and then the tool on the right is an education tool. And so on the left, they talk about antimicrobials and their checkbox, yes, checkbox, yes, no, for each of those things. On the right, it goes into a little more detail about what each one of them means. What is an antimicrobial? What is planned duration? So if there's no duration for that antibiotic, it prompts nursing to ask what the what the plan is for the antibiotic. And I can remember going up to one of our units when I was still in the hospital and asking, what is the patient on the antibiotic for? How long are they going to get it? When was it started? When is it due to end? And oftentimes nursing didn't know that piece. And so it was an opportunity for me to go into some detail about why those pieces are important. Nursing should not be giving antibiotics if they don't understand why the patient is getting the antibiotic. And then why IV to PO? And for me, from an IP perspective, it gave me the opportunity to not only help discuss, can we switch from IV to PO, but once we get on PO, then we can address when can that IV come out? Why else is that IV in place? And help them put a plan in place and address with the physician, when can we take that line out? So it gets those devices, going back to device stewardship, on the radar for someone to start paying attention to. Next slide. So this is just another good document. It's a 3-page document. And again, this was work done in like 2017, 2018. Mark Meyer is an ID pharmacist, but he's unique because he's also an infection preventionist. He is up in Southwest Colorado at Southwest Health. It's a small 25-bed critical access hospital. And he really took to heart putting together an antibiotic stewardship program and driving it. He started realizing that he needed a varied team. So from the get-go, he's always included RNs, and not just the bedside RN, but an RN educator, an RN from the ICU. And then he took it one step further, not just within the hospital, but he included their clinics as well. And he pulled in the RN that oversaw all of their medical clinics. So he really took a broader approach to antibiotic stewardship, including all of the outpatient clinics. The governance at his facility, the way they put things in place is that they met quarterly. They report to pharmacy and therapeutics quarterly, and from pharmacy and therapeutics, the information would be filtered out to the medical executives and to the board. They would provide updates to quality, infection prevention, and the surgical committees at least quarterly. And then if there were issues that came up, they would report more often. A good document to look at, he put in here what worked well for them and why they did some of the things that they did. Really impressive work. He presents across the country. He was involved in developing the National Quality Partner Playbook, and he was also involved with the PEW Charitable Trusts. So if you're looking for somebody who is a good resource for critical access hospital antibiotic stewardship, who is also an infection preventionist, Mark is a good one to reach out to. And he is very generous with answering questions and responding to different things. Next slide. So this, I just wanted to share some of the work that I've been involved with that directly affected antibiotic stewardship and antibiotic use. So when I was still at the University of Colorado Hospital as an infection preventionist, we developed I developed infection prevention champions. And one of the things that we did is we made sure that it was multidisciplinary. So we had lab, we had housekeeping, we had everybody in the hospital that would have contact with patients at any point along the way. And through the course of that work, the microlab rep mentioned that the blood culture contamination rate for the hospital was significantly high. We were almost at 7% across the board. And by national standards, we needed to be under 3%. So the champion committee took this on and decided that we would look and see what options we had, where we could make some improvements. And in looking, so in my mind, I thought it would be something fairly easy, not, I don't know what I was thinking, but we ended up needing to go back and clean up data. What we realized is that the we wanted to figure out what our target units were, where our problem units were. And we realized pretty quick that the lab was reporting blood cultures on the unit that the patient was on. So if the patient came in through the ED and then they were transferred to the ICU, when the blood cultures resulted 48 hours later, they were reported as an ICU result. So we went back and scrubbed data for 18 months, got good data, and realized that the real problem was in our ED and not in our ICUs. So we put together a targeted education approach, and we really focused in the ED, rolled out our education, and then monitored. And so over the course of about 18 months, we went from almost 7% blood culture contamination rate down to, in the ED, we dropped it down to 2.91, and our hospital rate, when we looked at it as a whole, dropped down to 1.97. And those rates continue to drop. Just before I left, the hospital's overall contamination rate was 1.76, and the ED was down to 2.35. We put things in place that, again, going back to the culture change, that we hoped would stay. And we reported this data out at our infection control committee and to the antibiotic stewardship team, because we wanted them to realize that we were making significant changes. And if there was a question as to why the blood culture contamination rates, why they weren't treating as many positive blood cultures, here's what we were doing. And so it was pretty impressive. Next slide. Again, taking that multidisciplinary approach and thinking about simple impacts that we wanted to make. One of the units in our hospital, we called it the ACE unit, the Acute Care for the Elderly. We had a really vested infection prevention team up there, and their CAUTI rate was 4.8 per 1,000 catheter days. CLABSI rate was 4.3 per 1,000 catheter days, and their hand hygiene compliance rate was only 78%. And so the medical director of the unit was really not happy with that. They wanted to improve hand hygiene, and they theorized, by improving hand hygiene, could we affect the CLABSI and CAUTI rates as well. So we put together an intervention, we rolled it out, really intense, and held everybody to the same standard that came onto the unit, regardless of whether they were unit employees or not. So the goal was to increase hand hygiene rates to above 90%, and that we wanted to see a drop in our infection rates. And the outcome was, 18 months later, we had increased our hand hygiene compliance to 97.2, and we were able to keep it between 96 and 98% consistently. What we realized, though, is over the course of 2 years after we rolled out our QI project, is that we had no iatrogenic infections on the unit. So they really, and we didn't do anything else on the unit other than focus on hand hygiene. So just, it was a nice way for us to show that we could impact antibiotic use, we could impact infection rates, we could reduce patient harm by taking those simple steps and focusing on one thing and not 15 things. Next slide. Which brings me to the end of my presentation. I like to always emphasize not taking that big, huge approach. I used to read to my kids, how do you eat an elephant? And you'd say one bite at a time. You can't hit a target if you aim at the sky. So start with one thing, think outside of the box, focus on that one thing that you want to change, work on changing culture, not just having things change when you're on the unit. If the only time things are done right is because you're around, you're not going to have it stay forever. So with that, I'll close. The references are there. You can, next slide. references are there for you. And if you have questions, my contact is there.
Terry, this is Vince. Thank you very much for that fantastic presentation. Is it okay if we share your slides with the audience?
Yes, it is.
Okay, thank you.
You're welcome. Thank you. It was my pleasure.
So what questions does the group have out there for Terry? Comments, questions?
Yeah, I wrote it in the chat, but I'll ask it here. This is Holly from one of the CAWs up in northeastern Montana. One of the things I'd like to tackle, I'm new to the position, only 3 months in, but one of the goals I have for this coming year is to get a little more involved in provider and nursing education. And I am wondering if you have any suggestions on how to go about this. We do like the end of the month reporting, but I'd like to be a little more proactive.
So are you looking for how to start approaching nursing, or more focused on what to take to nursing?
I think for in a CAW, we are very small. And
Right.
so our provider and nursing population works really hand in hand. And we are contained all in one building. So our ambulatory care, our acute care, our long-term care is all under one roof.
Right.
And so I'm looking for a way to address provider nursing education as a whole, but separate, to be a little more proactive with, the things you touched on.
Some of the things that we've done in those small critical access hospitals was like a monthly lunch and learn, where you just invite them all. And for us, it was really instrumental to find a time that worked. So instead of me saying we're going to do it at 11 o'clock in the morning on a Wednesday, which is crazy for providers because they're making rounds, they've got clinic visits, we would do evening. We would either have them bring dinner or cater dinner, and keep it simple to one topic, going back to that starting small. And so if you wanted to approach, a good one to start with both clinicians and nursing is diagnostic stewardship. Start with what it is and why it's important, because both physicians and nursing need to understand that piece. Why you don't want to order cultures in an asymptomatic person who has dirty urine, and how you can make improvements if you're not doing that. An example was I was working at a facility in Alaska for a few months, and in the ED, part of their standing orders were everybody got a urine culture. Didn't matter. And I was able, through looking at urine cultures for the C. diff patients, I would go back and look and see if they'd gotten antibiotics, when they got the antibiotic, why they got the antibiotic, and then I could tie it back to every case of C. diff in that short period that I was there was in a patient who was treated inappropriately with an antibiotic. They didn't have an indication for the antibiotic. So if I were going to put something together, I would start with something like that. Try and find a lunch and learn, invite both your provider and your nursing, and start with something as simple as diagnostic stewardship around asymptomatic bacteriuria.
Thank you. Great idea.
Okay.
And just to let you add, Holly, we will talk about diagnostic stewardship in one of our future sessions. There are, again, just like antibiotic stewardship, there are many different ways to approach this, and you really kind of have to tailor it to your specific group. So even though we could offer a lot of suggestions, you being the point person at your facility will know how how the group will react to certain interventions. And one thing I come to thinking, this is just what Terry brought up. Some reason someone must have for that urine culture to be automatically ordered anytime anyone enters the ED. Someone thought that was a good idea.
Right.
So it's not even just, so you have to kind of get the feel of why that was there in the first place. Otherwise, you're going to be paddling upstream trying to fight the changes because someone's convinced that that's the right, that should be done, and everyone else certainly probably didn't question it. So you have to undo all that mentality. So there is a bit of a, not saying that you shouldn't do it, but there's just is that you have to kind of get a feel, how do we break through that barrier of something that's been considered a standard because everybody believes that, and then trying to make those changes.
Right. And that was exactly what we faced in that facility in Alaska. Me as the interim being there temporarily even carried less weight because somebody did see that there was value in it. And so we had to take the data to them and work with them to cater to their population and to the community. Like Dr. Koo said, you need to really look at what's going on in your community and tailor the work that you're going to do.
Good. Another quick question from the chat there. In your experience, this is from Cindy, did including the nurses in the antibiotic stewardship program increase, decrease, or have no impact on workload?
Well, it didn't really have any impact on workload because a lot of it was stuff that they were already doing. What it did do, including them in antibiotic stewardship, and they talk about this in a couple of the articles, it improved their knowledge and understanding. So it actually drove more positive involvement. They understood why we as infection prevention or why antibiotic stewardship team members were asking specific questions or were pushing towards certain things, getting the duration. They really didn't care what the duration was. All they knew is they had an order for antibiotics and they were going to give it. And so what we did didn't change the workload. We just helped them understand why it was important to have a duration listed, or why it was important to make sure that peaks and troughs were done on time, and why timing was important. So,
yeah, I've always, my experience has always been in optimizing something. Eventually, retrospective reviews of it has always been that it improved time and workload and effort, so to speak. Now, in a hospital, there's always something, you make room on your plate, right? And something else fills in right away. So
getting them to understand the IV to PO piece, it takes a lot less time for them to give an oral antibiotic than to give an IV antibiotic. Yeah. You don't have to worry about a line infiltrating. You don't have to worry about the line running dry. There's all kinds of pieces. So it actually, like you said, it does decrease if they understand the benefit behind it.
Yeah. Yeah.
Good questions.
Yeah. Colleen has one. Have you changed your criteria for reflex cultures?
Yeah, tried, and Dr. Koo's smiling. We try, especially in a couple of the facilities that I've worked with, unless there's indications, it should not automatically go to a urine culture. Am I?
And I echo that. It's really a challenging thing. And it's one of the the quintessential thing that we talk about in diagnostic stewardship. But it's also an issue that is so ingrained in not just the nursing staff. I used to work in a nursing home. The knee-jerk reflex for every dirty looking urine is a UA and urine culture automatically, because in their mind, it's not just the fact that they look abnormal. They're most of those nurses think they're helping their doctors out. Right. And that's really what's happening. It's like, so they're not doing it because out of ignorance. It's really like, oh, I'm being helpful. So yeah, and it's a very big challenge to try to try to nudge them away from just automatically ordering stuff. And there's so many components to it. It's not just the dirty, right? It's not just the dirty urine, but any mental status change in anyone who's an elderly population automatically becomes a UTI unless proven otherwise. And so there's a lot of culture you have to break through and trying to do that. And we try to do some of that here at Billings Clinic. I mean, we have limited, we have now limited, at least there is no separate urine culture order. It's more difficult to get that, although you can still find ways to do it. And we have made set of specific criteria on our UAs with the results that if we're gonna do a urine culture, it has to meet a certain criteria or the lab will reject it. So there again, you kind of have to find what will work for your institution. But again, yeah, there is going to be buy-in. There's going to be a lot of chipping through that you know, the culture of this is what we're doing, because most everyone they're not doing out of ignorance. They're doing because they think that's the right thing to do, or that's the standard of care.
Right. That's how it's always been done.
And just to answer Colleen's question, what some of those criteria is, usually we kind of reject based on really primarily on the number of epithelial cells. You know, it gets a little tricky. You know, we usually kind of give it like 5 or something like that, depending on how the cultures, how the specimens are being collected. Bear in mind that as you're tweaking some of those criteria to restrict cultures, you're going to run into clinicians who are going to come up with those exceptions and find that they get really upset because they missed the diagnosis because of that. So that's the other part of the challenge about diagnostic stewardship. As you're starting limiting, just like antibiotics, you are also, you know, they're going to feel very nervous about the possibility of missing diagnoses. So it's trying to find a happy balance, but you know, so there's a component of education, there's a component of actually, you know, changing things in the computer system, how the labs handle the specimens, and as well as you know, again, try that basic, you know, and I'm glad Terry, you brought up a lot of the how influential nurses are in these matters, because a lot, even here in Billings Clinic, many decisions are being driven by what nurses tell their providers. and so, you know, but on the other hand, one of our biggest challenges is that we are relying on our nurses to do so many other things that I don't know we can even get them to critically assess and to help guide their clinician what's the right thing to do too. So that's another big challenge as well.
And that's where you start with that small bite. Start with one small thing and help them see the benefit of what they bring to the table. And then they slowly buy into it.
I want to be respectful of everyone's time here. And I think is B-Rad, do you have your hand up for a question? I want to get to you because you had it up first there.
Yeah, I do have my hand raised. Thank you. I'm a public health infectious disease specialist. I work at the Missoula City County Health Department. I'm a nurse. I really appreciate what you said about bringing the nurses into the equation, and even your community approach where you were talking about clinics and like satellite clinics beyond just the hospital, the nurse that would oversee those. And maybe this isn't the time to answer the question since we only have about 30 seconds left. This might be a topic for future discussion, but I'm really curious about how can a public health nurse, infectious disease specialist like myself become more involved, going beyond the hospitals and clinics and having that community perspective and that community role.
Ooh, that is a big one. I'd have to think on that a little bit. I mean, I've done some collaborative work with health departments in a couple different states, and we did some collaborative work here. But I think your question is more pointed with a community health department versus a state health department. I can, unless Dr. Koo has a response, you know who might be able to answer that, and I could pose that to Mark, but Mark Meyer in Southwest, because he has done community level work. And I know he worked with the state health department here in Colorado. I'm not sure how much he did with the with his local community health department. That's a bigger one to bite off. Definitely some great value in it, but I think that's just a harder one to.
No, I agree with you. You're in some ways kind of hurting cats because you have
Right.
so many different entities doing their own thing. It's a lot easier when, with stewardship, it's a lot easier when it's all contained in one system and you have using one EMR. So when you're dealing with different people, I mean, I'm not saying you can't do it. It just requires a lot of effort. And the question is how much resources are anyone willing to allocate to do that? Because it's
Right.
not going to be cheap or even, I mean, I'm not even talking about monetary. I'm talking about personnel to try to coordinate the effort. You got to get all the pharmacists to work coordinated. You got, since they're all, dealing with different labs. So you kind of see it's a much bigger challenge. Now, with that being said, one of the big new upcoming topics is actually talking about doing antibiotic stewardship on an outpatient basis, but that's a lot of it's really kind of are for outpatients clinics of one healthcare system rather than a multiple within a region. So there's just a lot of challenge. So and to answer a question about education for long-term care, there is the SHEA website should have actually offers some educational sessions on that particularly. Actually, even a recent one talked about COVID-19 and how to manage that in a long-term care facility. What I'll do is I'll ask Erica to send out a link to the SHEA website to know where to access some of these information.
The National Quality Partners actually developed a playbook specific for long-term care as well that is worth looking at if you want some ideas. They've got the links. It's just a very good tool to use.
Yeah, Terry, thank you very much. Is it okay if we share your website, and excuse me, website, but email that if someone
Yes.
has a follow-up question?
Yes.
Okay, very good. Again, I want to be respectful of everyone's time. I know everyone's busy. Thank you for joining us again. That was a great question, B-Rad, and something for us to ponder in a future presentation for sure.
Hey, Vince, this is Pam. I just wanted to respond to B-Rad's question, if you don't mind. If you have do you have a clinic pharmacy that's attached to your outpatient clinic or the Missoula Public Health Department?
Not really. We
Okay.
have Partnership Health Center in Missoula, and they're a separate entity. We're both public health agencies. They do more of the direct patient services, like
Oh.
Riverstone and Billings, I think, model. And they do have a pharmacy, but I work out of a separate entity called the Health Department, and we do more follow-up.
Okay.
For like the
Because I was
7
thinking you could
reportable conditions.
you could just bring that information to them, maybe if they haven't started something, or try to work with them, in that small piece.
Absolutely.
Okay, I'm muted now.
No, good comment. Okay, thank you very much for everyone for joining us again. Great feedback, and we're actually really enjoying the conversation that is happening. And once again, thank you very much, Terry. That was a great presentation. We appreciate that
Thank you.
a lot.
You're welcome. My pleasure.
Okay, see you all next month.
Thanks, Terry.
You're welcome.
Thanks, Pam.
Hi, Jenner. I can't hear. Are you
Hi,
muted?
Marley. How are you?
Good. How are you?
I am doing well.